Inspection of the patient with cervical pain is critical in terms of evaluating all of the structures that relate between the head, the neck, and the thorax. In addition, one must also take a look at the shoulders, as there may be potential signs of cervical dysfunction identified in the shoulders. Here we can see that the left sternocleidomastoid is more prominent than the right. You can see that the left shoulder is higher than the right, and you can also see that there is slight deviation of the jaw towards the right. Here from the side position, we can see that the head is slightly forward on the neck. The neck is slightly straightened, but yet the shoulder and the thorax are in good position relatively to the remainder of the head and neck. Here the patient is intentionally performing excessive forward head thrust and forward neck thrust. This is a typical position for many patients and is one that needs to be evaluated and treated through your treatment program in a patient with cervical pain. Now the patient attempts to provide normal posture again, and I even asked the patient to perform proper neutral positioning, but it took my hand positioning to place her into good neutral positioning. Now we evaluate the patient from posterior. Again, take a look at the position of the shoulders. Again, one will note that the right shoulder is slightly lower than the left. It is not uncommon for the dominant side to be lower than the left for reasons mostly associated with excessive wear on the right side in this particular patient. Also take a look at the muscle bulk. Also take a look at the position of the scapulae comparing the right to left. Also will notice that the jawline is a little more prominent on her right side. Here we evaluate the patient from in front, looking at muscle bulk in the shoulders, thorax, biceps, triceps, and in the forearm. Again, note that the left sternocleidomastoid is more prominent than the right, and again the jawline is slightly deviated towards the right. Note that the ears are symmetric with respect to their inferior and superior position, again suggesting that the deviation is actually within the jaw and not within the position of the head. Now the patient is asked to intentionally flex the muscles of the upper body. Look at the pectoralis muscles, deltoid, biceps, and triceps. Note that the muscle bulk of the right upper extremity is greater as compared to the left. This patient is consistently involved in throwing and other racket sports, which is probably responsible for this. The patient is now evaluated from behind with muscles contracted. Again, look at the triceps, biceps, forearm musculature, and begin to take a look at the position of the scapulae, again as we're going to note what is taking place within the shoulder, as this again may be a sign associated with cervical pathology. Much as we did with our shoulder examination, we will perform the same tasks here. The thumb is placed underneath the inferior angle of the scapula, the index finger at the medial border of the scapula, and the third digit over the superior angle. The patient is asked to place his or her hands onto the hips, and again we note whether or not there is excessive lateral deviation or hiking of the scapula, one side compared to the other. Note that the right does tend to move a little bit more laterally and upward as compared to the left. You can measure this with a tape measure or do a simple measurement as I do here using your fingers for an approximate judgment. It is critical to understand the mechanics of the shoulder as they relate to the cervical spine, as this is a potential source for pain in and around the shoulder area. Now the patient will perform an abduction, adduction cycle with my hands placed over the scapula to detect whether or not there is asymmetry side to side. My hands are now removed so I can evaluate this motion from a distance. Here you'll note that the motion is actually quite symmetric overall and no significant asymmetries are noted. In addition, you'll notice that the right shoulder is actually slightly better in overall position compared to the left. Again, with the hands on hip position, see how the right scapula becomes more prominent. As she retracts her scapula, you can see that the musculature of the rhomboids and trapezius are more prominent on the right than they are on the left. From the remainder of the examination, this will typically be performed from the seated position. Here, the patient is asked to rotate the head towards the left. I place my thumb directly underneath the chin as she does so. I then perform the same with my right as she rotates towards the right side. When I ask her to go back to the left or to the right, I can see whether or not she is consistent with her movements on each attempt. The same can be performed when the patient is asked to laterally deviate the head or laterally flex to one side or the other. Again, the scapulae and shoulders are stabilized. I place my left thumb underneath the chin at the angle between the chin and the nose, again to see whether or not there's any symmetry, and if I need to evaluate consistency, the test can be performed several times. Here I use an angle measuring device called an inclinometer. The red needle demonstrates how much motion is occurring, in this case towards the left into lateral flexion or into right. This patient has slightly greater lateral bending capacity towards the right than she does towards the left. The next portion of the examination is to perform an axial load onto the cervical spine to intentionally cause compression to the posterior elements or into the neuroforamina. This is known as Sperling's maneuver. Here, the patient is forcibly placed into excessive flexion. This is called the Lermit's test. I'm intentionally trying to reproduce symptoms into either both arms or along the spine, potentially associated with cervical cord pathology. Here, the patient brings her head into full flexion and then into full extension. You can take the angle between the nose and the external auditory meatus in this position to tell you exactly how much extension is present, or you can use an angle measuring device like is shown here. If I was to place my fingers underneath her chin, it would be approximately 2 finger breadths in distance. You can also record this as a measure. Here is a spine model that shows what is taking place approximately when we perform our lateral bending. The attempt is to cause compression into the small joints or into the lateral aspects of the discs. Here, an attempt is made to perform an extension maneuver. Again, most of the pressure will take place posteriorly. As we move into flexion, most of the pressure occurs onto the anterior aspect of the discs and will actually open up the neuroforamina. Now the neck is brought into the position consistent with Sperling's maneuver. The attempt here is to provide as much force as possible onto the small posterior elements or to compress the neuroforamina, potentially reproducing symptoms locally or distally. The palpation examination is absolutely crucial to evaluate the structures in a patient complaining of cervical pain. Here the patient is placed in a supine position. I use the entire fingers for this portion of the examination to increase the sensitivity. The fingers are placed directly into the musculature and into the bony elements of the spine. I palpate along the spinous processes. I then palpate into the muscles and small bony areas around the cervical spine, trying to evaluate the degree of tone within these muscles and also to determine exactly where I'm located anatomically. I palpate at each of the different levels as I go up or down, trying to introduce symptoms and also to get an idea of where I am anatomically. Here I'm at approximately C3-4. Now we're at about C4-5. C5-6, and approximately C6-7. This is now down approximately C7-T1. I begin palpation of the sternocleidomastoid, both the anterior and posterior heads. Also palpate into what is known as Erb's point, or the scalene, and portions of the brachial plexus. Now I begin to evaluate how much movement is taking place at the cervical spine by performing the movement passively. We saw what the patient was able to do actively, and we compare this. I now place my fingers at different points along the cervical spine to introduce movement where I want it. I can then determine exactly how much lateral bend is possible at each level. The first test is called the Roos test. The patient claps the hands back and forth and does this for at least 30 seconds to 1 minute. If the patient has compression to the blood vessel going to one arm as compared to the other, there will be a steal phenomenon leading to one side becoming white or cold and reproducing symptoms. The next test is called the Adson's maneuver. Here the examiner places his hands onto pulses on both hands. The patient is asked to rotate the head towards one side, extend slightly, and take a deep breath in. The patient is asked whether or not this reproduces any symptoms, And in addition, the examiner is evaluating for whether or not there's a pulse dropout within the hands. If there is a dropout of pulse, this could be suggestive of involvement at the scalene muscles causing compression to the vascular structures. The patient is then asked to rotate the head towards the other side, and the test is performed again. The next test is known as the Wright's hyperabduction maneuver. The pulse is palpated as the arm is slowly brought up to different angles of abduction. Again, the patient is asked whether or not this reproduces any symptoms. Again, the examiner is looking for any pulse dropout or reproduction of symptoms. Theoretically, if a pulse dropout occurs, it is thought that this takes place underneath the pectoralis minor muscle. Next test is known as the costoclavicular maneuver. Here, the examiner is palpating both sides as the patient intentionally thrusts the chest forward. If compression of the vascular structures occurs between the first rib and the clavicle, this theoretically can cause compression and cause pulse dropout with this test.